The triple aim is a concept that tries to capture the social need from healthcare. What are we here to do? And it says that the accomplishments society needs from healthcare are first, better care. So if you get sick, all of the dimensions of improvement that are described in the IOM report, Crossing the Quality Chasm, are brought as close to perfection as possible. Safety, effectiveness, patient-centered care, timeliness, efficiency, equity, great care. But that's not good enough. The second aim is better health. And that's not really achieved through the care system. It means we have to work on the causes of illness: obesity, substance abuse, inequity and poverty in society, the kind of sedentary lifestyle we become accustomed to. So it's achieving better health. And the third is doing all of that at lower cost, not by withholding what people need, but lower cost through improvement of the processes of care and the processes through which we prevent illness. The triple aim: better care, better health, lower cost. That's what society needs us to focus on. There's no way to achieve the triple aim without tackling issues of equity. First of all, coverage, just people having access to health care. How can we have great care or even better health if people can't get into the care system? And our country still has not achieved the kind of universality, the fact of healthcare as a human right that I think is the foundation for the improvement of health and healthcare. It also would reduce costs, because one way to make sure costs go up is to leave people without care, and so they have to wait until things are worse, and then they come in and it's more expensive to care for them. The other forms of equity have to do with the underlying generators of illness. Once you're in the system, can we really make it possible that every human being can maximize their achievement of the health status they want? We don't have that right now. Right now, your wealth, your race, your ethnic background are far too correlated with the actual outcomes of care. We need to build a more equitable system so people can get care that closes those gaps. That means a system more customized to individual needs: your language, your background, your resources, your particular needs. We cannot have one-size-fits-all healthcare in this country. We have to have a healthcare system organized around the needs of the individual, and that involves equity, because every individual needs that care. The most vulnerable Americans, the people who have other sources of disability or burdens in their background, people who are marginalized in our economy, are low income and really stressed, people who have have their own languages and their own ethnic backgrounds, people who stay at the margins, have particular needs. We need to address those needs. And yes, it's more difficult. Someone that comes in with all sorts of resources and money can have an easier shot at getting the care that they need. That's the gap we need to close. To do away with the idea that in America the color of your skin or your ethnicity or your wealth actually predict your access to care. One of the ways we can do that is to discover the abundance in the communities of people who we currently regard as disadvantaged. Those people have tremendous resources in their social networks, in their cultural backgrounds, and so a healthcare system that it embraces more is going to find resources in those communities. But committing to closing those gaps in access and quality of care is really central to the triple aim. The triple aim is ambitious. It requires healthcare to change. We've built a healthcare system in this country that's largely organized around better care, especially events, treating your heart attack when you have it or fixing your broken arm. That's not good enough. The society needs us to focus on the causes of illness and really move upstream. That's just smart. And we've just spent too much at 17 or 18% of the gross domestic product, headed for 20, headed for 22. That's too much. Healthcare can and should figure out ways to achieve better care and better health at lower cost so that those resources can be used for other purposes. My message to providers is we are going to solve this problem together or not at all. The idea of accusation, attack and defense, people accusing providers of not wanting to meet those needs, or providers accusing policymakers of being unrealistic, we've got to get over that. This is a time to really draw together as a nation to achieve the kind of equity and respect for every human being that our nation was founded on. And that's not a blame game, that's a cooperation game. For providers, I think they need to know that this is difficult. Achieving the triple aim for disadvantaged and minority populations in our country can be very, very hard. It stresses us. We have to figure out new and better ways to give care, but we can do that. We can do that once we decide to do that. So I would just encourage providers to have the confidence, the self-confidence, and the generosity of spirit to join together now and close these unacceptable gaps in equity and access to care. I know we really can do it. One of the really exciting things about trying to address disparities and achieve equity in healthcare is that it invites so much creativity. We're not going to achieve that with the system as it's currently designed. We're going to have to be as inventive as America can be, as inventive as the Northwest can be, and find redesigns that really work. As we explore that, some of the principles that are going to emerge are going to have to do with widening the boundaries of healthcare, involving communities, drawing on the assets and relationships that people have, even in stressed communities. And I think really authentically putting patients, families, loved ones, communities at the center of the care design, getting out of our heads, out of our institutions, the frameworks that bind us, and looking at the entire community. That's a really important thing to do for closing the gaps in equity. But we'll learn to do that for everybody if we do that right. So this is a time for very exciting innovation in this field, and I look forward to Oregon and the Northwest showing us what some of those bold new redesigns can look like. The state of Oregon and the Oregon Primary Care Association are thrilling to watch. This is one state in America that has really chosen, as a matter of policy, bipartisan policy, to make healthcare a human right, to make sure people gain access to the kind of care they want and need, to make care continuous and seamless, and to address issues of equity and closing those disparities. I'm very excited about what's possible to achieve in Oregon. It's going to involve change, and the providers and payers and government, all the stakeholders in Oregon are going to need to come together to recraft a healthcare system that can achieve the kind of equity that state seems to want to achieve. Oregon can be a prototype for the country. We need one successful state, maybe all that this country needs to build its confidence that these gaps don't need to be lived with, that we can close it. So, as I said before, bravo, Oregon. You can show us what to do.